we talk about how 83% of you watching right now are not subscribed? Whatever reason you're here, welcome. I am so happy to have you. And here's what would make me even happier. If you hit the subscribe button now, you have the power to help this channel grow and to reach people who really need these conversations like you. Your support really matters to me. Thank you. Guys, have you found yourself in a sexless relationship? Menopause might be the reason. Today, I am joined by Dr. Lauren Streicher. She's a clinical professor of obstetrics and gynecology at Northwestern. She is the founding director of the Northwestern Center for Sexual Medicine and Menopause and senior research fellow at the Kinsey Institute, one of the nation's leading experts on women's sexual and menopausal health. She's the author of Hot Flash Hell, I love these titles, Sex RX, Slip Sliding Away, and the Essential Guide to Hysterectomy. She also hosts the podcast Dr. Streicher's Inside Information, Menopause Midlife, and more, and has another one coming out soon. Welcome, Dr. Streicher.
Well, thank you.
I'd like to talk about helping women and men have enjoyable sex, but first I want to ask the question, is menopause an old woman's problem?
One would think, you say menopause and everyone's picturing grandma, and they're picturing grandma who it's like no one wants to picture their grandma having sex, right? So everyone is thinking, well, menopause is 10 years older than I am, or this is only older women. The truth is the average age of menopause in the United States right now is 51, but that's average, and it is not unusual for women to enter perimenopause in their mid-40s. But then we also have a significant number of women who are younger, even in their 20s and 30s. Why? Well, very rarely, but it can happen that someone has a genetic reason to enter menopause early. But we also have women that are entering menopause as a result of maybe cancer treatment or surgery. So this idea that menopause is just women in their 50s, 60s, 70s, 80s is simply not true.
So how does menopause affect sex life? Now, I've talked about this a lot, but we can never talk about it enough.
All right, well, let's just start with something that is not talked about enough. It's not like women have amazing sex before menopause. I mean, there's this idea that everyone's having mind-blowing orgasms, sex every day, and then all of a sudden menopause comes and it's, whoop. Let's just deal with the issue that we have roughly 40% of the general population, and I'm talking women, I'm a gynecologist, and so we're looking at 40% of the population that is having some sexual problem, maybe not throughout their life, but at some point in their life, whether it's pain with sexual activity or low libido or difficulty with orgasm or inability to become aroused. So we have to start with a baseline that's not necessarily perfect. So let's just go there, okay? So then what happens is when you look at what does it take? What does it take to have normal sexual response? And we're not talking psychosocial stuff because I'm a gynecologist. We're talking the biology, the medical stuff, all of that. So what it takes to have a normal sexual response is, it helps to have hormones, not absolutely required, but it's really helpful. There needs to be good blood supply. We need to have nerve endings that are sensitive. We have to have muscles that are going to contract and relax. There's a lot going on. Neurotransmitters, all this stuff. So what happens at menopause? Well, menopause is basically when our estrogen tank is on empty. Estrogen plummets. What happens as a result of that? When we look specifically at sexual issues, keep in mind that we have estrogen receptors throughout the body. It's not just the vagina, the vulva, the clitoris. You have estrogen receptors in the brain. You have estrogen receptors in your muscles, in your bone. I mean, really, we are talking throughout the body. So it's not as simple as people think. It's not like, oh, now I'm having vaginal dryness and that's why I'm having sexual problems. Because when we go through all the potential sexual problems that someone might have post-menopause, a lot of it might be because suddenly they're having painful sex and they never did before. That's an easy fix. Loss of libido. Maybe that's because they're having painful sex and their vagina's telling their brain, don't go there. Or it may be that the estrogen receptors in the brain, in the sex centers in the brain, are not being as triggered as often. It may be that your hot flashes are keeping you up so that you are exhausted. And when you see that pillow, you're not thinking about sex. You're thinking about maybe tonight, God willing, I'll get a good night's sleep. So when someone comes into the Center for Sexual Medicine and Menopause, when I'm talking to a woman about this and she tells me, I just went through menopause and my sex life is really a problem, I have a lot of detective work to do. I have to really kind of go through and talk about not just what's going on in her sex life, but what's going on in terms of her sleep, in terms of her hot flashes, in terms of her brain fog, in terms of her general anxiety levels. And then there's, all the physical stuff. Are you having vaginal dryness? Are you having aches and pains so you can't even get your legs apart to have sex? So it's a lot. But now, having painted this horrible, terrible, dismal picture, I am solution-oriented, and I'm here to talk about solutions for all of these things that hit. And we've even gotten into if there's a partner and what's going on with his penis and him. I mean, that's,
right.
There's that too.
So your clinic has the word sexual medicine in it, but I'm wondering how many women actually come in and say, my sex life sucks, I want to have more sex.
They all do.
They do.
Okay, so let me just be clear about this. First of all, I'm actually not at the clinic anymore. I was the founding director. I started it. I ran it for 6 years, trained everyone, set all the protocols, and then I left post-COVID because I wanted to do other things. So when we talk about sexual medicine, that clinic was intended for young women with sexual problems, very specifically. Okay. But this is the thing that's really striking. How did women get to that clinic? When I first started this clinic, I thought, well, most doctors don't know much about sex, and they're not trained in it, and they're going to be so happy to have some place to refer their patients. So I was going from department to department, oncology, internal medicine, cardiovascular clinic, all of that, and talking to the doctors and saying, good news, you don't want to deal with this stuff. I have someplace for you to send your patients now. So when women started coming, and boy, they started coming in droves, we would ask them, part of their intake questionnaire was, and who referred you? It wasn't their doctors. Their doctors were not sending them. I'm like, are you kidding? I just spent the last year talking to all these doctors, and they're not referring their patients. Women either got there on their own through just going on the internet and saying, Chicago Sexual Medicine or Chicago Menopause, something like that, and they would come up with their clinic. Or maybe a friend or someone they knew, or a sex therapist had sent them, or a pelvic floor physical therapist had sent them. It was the rare woman that was referred by a doctor, and if they were, it was most likely an oncologist.
You say that oncologists were referring patients. I hear so many women who've had cancer. Sex was never even in the realm of conversations. Yeah. And that's sort of interesting that an oncologist would refer their patient at this point.
When I say oncologist, I should have said the Department of Oncology. Okay. Because what was really going on is at Northwestern, there was a very, very large, very good Department of Oncology. And part of this was a survivorship clinic. And in the survivorship clinic, when they would come afterwards, they would see a nurse practitioner, advanced practice nurse. And we had spent a lot of time talking with them, and they would talk about sex with their patients. So, number one, we saw them for that reason. Number two, in oncology, they tended to be younger. So, when you think in terms of who gets referred for sexual issues, it's the 20 or 30-year-old more than the 50 or 60-year-old. So there was that. And then the other reason is we happened to have a CO2 laser program to treat vaginal dryness, and we had a program where women who had a breast cancer diagnosis didn't need to pay for it. So there were a lot of things that came together, but the number one reason is the survivorship clinic. They would very often end up referring patients.
Well, it's nice to hear that there's more resources for younger women, because certainly in our generation that wasn't the case.
No, it was not.
I mean, I even share my experience, and I had a pretty progressive, I was on hormone therapy fairly young by our standards in my late 40s, and when I went to my doctor, I was newly single, and I was having trouble orgasming, and I was on hormone therapy. I had no correlation. I wasn't doing this work, and I had to ask her a couple times before she referred me to a sexual medicine practice.
And there was one to refer you to.
Yes.
See, that's the other
that was in
thing,
New York
too.
City, so of course there was one.
Well,
to send
exactly,
me to, right.
And that's the other barrier, is that it's one thing to know that you might benefit from someone who is a sexual medicine expert, but finding them is a very big challenge. And if you're in LA or Chicago or New York, it's still not easy, but they're there. If you're someplace else, good luck.
What about all these online clinics like MIDI and Alloy and...
Well, so this is the thing. And I actually worked with MIDI for a few years as their director of patient education. I wasn't seeing patients with them. I was the one who was out there giving all the talks. I really did a complete turnaround as far as telehealth, because if you had asked me 7 or 8 years ago, what did I think of telehealth? And I would say, oh my God, no, it's terrible. You have to see a doctor in person. And I've really, really changed on that. And of course, like a lot of things that happened during COVID, what you realize is that you can get very good medical care if it's done correctly online. And there are some things that are better done online than in person, and other things that are better in person than online. So when you're looking at menopause care, and MIDI, and there are others that also do a very nice job, they had incredible training in terms of the clinicians, and it was really, 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 they did a terrific job as far as treating a lot of the more common symptoms, hot flashes, etc. When it comes to painful sex, it's a little trickier because when we think in terms of painful sex, the number one reason for painful sex postmenopause is vaginal dryness. And if someone is complaining of vaginal dryness, that the onset was coinciding with menopause, well, very often that usually is the problem. And you can start with using a local vaginal estrogen, DHEA, something such as that. And in many cases, that will solve the problem. So that's fine to do that online, with the caveat of it's critically important to do a follow-up a month or so later, 2 months max, to say, how are things going? And if someone says, I am faithfully using whatever was prescribed to me, but I'm still having trouble, telehealth is no longer an option. And there's a lot of reasons for that, but one of them is sometimes the diagnosis is completely different. There are a lot of other conditions that cause painful sex that can hit postmenopause. Lichen sclerosis is at the top of the list. Very often you could be treating the tissue, but you haven't treated the tight pelvic floor muscles. That cannot be done without an exam and with the work of a pelvic floor physical therapist. So can this be treated with telehealth? Initially, yes, but some things require an in-person visit.
The other downside I recently heard from a girlfriend is that when you're a Medicare, you're tapped out. Like, they don't take patients over 65.
It depends on
for menopause care.
MIDI does not take Medicare. Last time I checked, there may be other online options that do, but I can't speak to that. But listen, it's a problem. It's a problem. And, when we look and talk about someone who's over 65, life expectancy is well into the 80s, close to 90. We have women who are single, who are out there, that it's important to them. And they can't get care over 60, 65. And in fact, whatever research there is pretty much stops at about age 55 or 60, even in the postmenopause care. So, one of the questions that comes up is, well, when are you done with menopause? When are you done with menopause?
Never.
When you die.
Yeah.
Because menopause is that you're no longer making estrogen. And what most people are referring to when they say done with menopause is when they're no longer having hot flashes. And they think, okay, now I'm done. Well, your vagina is never done. You are never going to start making estrogen again. Your bones are never done. There are a lot of other parts of your body that are never done. And just because you're not having symptoms doesn't mean that you still may not have the repercussions of menopause. Now, having said that, not everybody has problems postmenopause. I just want to be very clear. One of the things, a lot of the work I do and a lot of the research that I've done is specifically in orgasm postmenopause. And one of the fun facts is when we look at biologically what it takes to have an orgasm, estrogen is not on the list.
Well,
you can have an orgasm with
testosterone, right?
No, testosterone's on the list either. And in fact, if you look at what does it take? What does it take to have an orgasm? Well, you need clitoral blood flow, you need intact nerve endings, you need neurotransmitters that are firing appropriately, you need pelvic floor muscles that are going to contract. And when I teach the medical students, and I have my whole big fancy chart up there about this is what it takes to have an orgasm, estrogen is nowhere on the list. Testosterone is absolutely has nothing to do with orgasm, quite frankly. Testosterone is more about libido, a little bit of arousal stuff, but you don't need testosterone to have an orgasm. You need arousal to have an orgasm. But having said that, estrogen is not required. Does it help? Oh yeah, it helps a lot. Why does estrogen help? Well, it helps with arousal, it helps with lubrication, it helps with blood flow, it helps with clitoral health. So it helps. But the point is there are plenty of women out there who are postmenopause who do not take estrogen, who do not take testosterone, who have wonderful orgasms, who have a terrific intact libido, and have a great sex life. And I really am going out of my way to point this out now, because on social media, if you spend any time on social media and you're a woman who's, let's say, in her late 50s or 60s and was not offered hormone therapy, and they're sitting there and going, shit, it's hopeless. And no, not at all. Not everyone needs to take hormones. I happen to be in the camp that hormone therapy is safe and effective, and for many women they benefit from it, but it is not something that every single woman needs to do. And every single woman does not need to take estrogen in order to have a terrific sex life. Having said that, some women need a little estrogen love. If you've got vaginal dryness, you need to do something, if not estrogen. There are estrogen alternatives, but you need to do something to improve the health of that tissue. So it's so individual. It is so multifactorial. And we haven't even gotten into all the psychosocial stuff and relationship and, getting a decent night's sleep and all of that. It's complicated. And it's frustrating for women when they go to their doctor, and who may not be an expert anyway, and then they spend like 3 minutes talking to them. A sexual medicine consult takes me, if I do it right and really spend the time, 90 minutes.
Wow.
90 minutes to really do it, I can do it in a lot less. I can do it in 15 or 20 minutes if I have to, but not the way I want to do it.
So let's talk about high level, the top causes of painful sex for women. And then I want to shift a little bit to how we can help educate the men out there who are supporting these women.
Well, when we look at painful sex, I actually am very involved in the Menopause Society. I do a lot of academic work in addition to the work I do here. And I was asked to write a review article for the journal Menopause, I think it was about almost 3 years ago now, on post-menopause dyspareunia, dyspareunia being the medical word for pain with penetrative sex. So we are talking vaginal penetration. There's lots of other sex, but I just want to define very carefully. Okay. For this purpose, we are talking about either penis in vagina or toy in vagina, penetrative sex. Pain with either trying to do that, or if you're having penetrative sex, there's pain. And one of the things that I looked at when I started to write this paper was the editor of the journal who'd asked me to write it. And it's because, believe it or not, there was no definitive paper on dyspareunia after menopause, because every single paper out there was specifically about vaginal dryness, genital urinary syndrome, or menopause. And no one had really addressed it on a much bigger picture. So, this is a more case of be careful what you wished for and be careful what you say. I was so honored. It was like, yes, of course I'll write this paper. Well, 9 months later, 80 pages later, with I think there was almost 300 references, and I turned it in, and they laughed at the journal and said, no, you've got to cut this down. So at some point, maybe I'll publish it as a book. But the point is that this paper, which was really the definitive work on postmenopause sex, I had over 50 diagnoses beyond genital urinary syndrome. Wow. And the reality is that when you treat painful sex, you have to have an accurate diagnosis. So to my earlier point, these women go to a doctor, go to telehealth, and say it hurts whenever I try and have sex, and they be given estrogen, vaginal estrogen. And then if it didn't work, they just thought, well, it's hopeless. And no, you just need to get a correct diagnosis. So the treatment for dyspareunia is 100% dependent on diagnosis. And it's not unusual to have more than one thing going on. But when we talk about, let's go for low-hanging fruit here. Okay, let's talk about the most common thing, because when we think in terms of vaginal dryness, I will tell you that no matter what other diagnosis someone might have, of those 50 other diagnoses, very often they also have vaginal dryness. Yeah. So we're going to end up, treating that likewise. And you know how whenever you talk about vaginal dryness, and everyone always says, well, the first thing is, lubricants and moisturizers. Oh my God, could we please stop that narrative? By the time someone comes to my clinic, they have tried every lubricant and moisturizer on the planet.
And all the oils in the kitchen.
But the point is the idea that that's the first line. Oh, please. We need something that's going to repair this thin, dry tissue. And the only thing that's going to do it is a prescription product. And whether that's a local vaginal estrogen or DHEA progesterone. I don't work for any of these companies. The trade name is Intrarosa. There's Espemifene, which is a oral selective estrogen receptor modulator. There's a lot of choices out there, but you need to use something that's going to work. And no, estrogens are not all the same, vaginal estrogens. And that's one of the big problems, is that a woman is told, well, all these vaginal estrogens are basically the same. Which would you like? Would you like a little tablet? Would you like the insert? Would you like a cream? Would you like a ring? And while they all have the same active ingredient, a beta estradiol, other than the conjugated estrogens, but they all have the same active ingredient, the products are all different. And you know why? Because we're treating both the vagina and the vulva. Everyone always talks about their vagina. They're really talking about their vulva. The vagina is inside that you can't see. The vulva is on the outside. And so what happens is women are very often given a product that treats the vagina inside, but the vulva, the vestibule, the opening to the vagina is still dry and painful, and it doesn't matter how nice the room is if you can't get through the door. So when we think in terms of treating vaginal dryness, genital urinary syndrome, or menopause, which encompasses more than vaginal dryness, of course, but it's not just about, pick your estrogen, any estrogen. It's which product is going to be the one that is going to give you the most likely benefit that, you're going to get the result that you want. And again, we're looking at individualized care. We're looking at a careful exam to see where is the problem and then to put together a plan that's going to solve it. I did an article that I almost didn't do a month or so ago that's 20 common questions about local vaginal estrogen. And it was just 20 frequently asked questions about how to use it. And I thought, well, I don't know how this one's going to do. You never know. It exploded.
I'll put a link in the show notes.
And then with that came lots more questions. I thought, I'll just kind of jump on and do a Substack Live, which I really hadn't done before. But I thought, well, I'll give it a try. I didn't know what I was doing. I just said, I think I'll go live. I went live and said, I'm talking about local vaginal estrogen. I think I had 200 people on within about 10 minutes. If I had been willing to keep that live going for 2 hours, it would have kept going. And so we forget that they're doctors. And that was actually the most common comment I got was, my doctor never told me this. I mean, one little thing I started, I think was the first question on the list, is that when you put vaginal estrogen in your vagina, where do you put it? Women are not told that. They just they're given the prescription and put it in your vagina. And what do women do? Well, they do what they did when they put a tampon in their vagina. The higher, the better, right? Except all of the hormone receptors are in the lower third of the vagina. And women are shoving this stuff up on your cervix. Your cervix doesn't need the help. The lower third of your vagina needs the help. And even that one little thing made a huge impact on women saying, OMG, no one ever told me this. And these are smart women. These are not.
No, you taught me that with the lower part of the vagina too. I did not know that.
Women, and these are women who are smart, who are educated, who have been to a good doctor, who've gotten their prescriptions, and they're not told. And quite frankly, their doctors may not know.
That's interesting. Let me ask you this, though. What is there a risk, because that is what, we're still fighting that battle, especially for postmenopausal women, in using topical estrogen in whatever form?
There are no risks. There are no risks. And I don't say that lightly, because there's nothing in life that doesn't have a risk, right? Local vaginal estrogen is, basically as no risk as it comes.
You heard it here from the professional.
Well,
okay?
I know, but this is well studied. And this is one of the things about me that you may not know, and certainly your listeners may not know. I'm a total data geek. I don't say things that's my opinion. I mean, of course I have opinions, but when I am talking about this stuff, I am saying anything based on the data. And if there is no data, I will say, you know what? We don't have good data on this. I can tell you what I think from my experience. I can tell you what I think based on the biology, but we don't have data. And one of the issues with local vaginal estrogen, of course, that label, that scary warning label, and this is because of class labeling. If oral estrogen caused blood clots, then they sit there and they put that on the vaginal estrogen label, even though that's not shown to be the truth. But I think the biggest thing that people worry about with vaginal estrogen is this going to increase my risk of breast cancer? And the answer is no. We have about 1 million studies that show that that's not the case. And if someone has a cancer diagnosis, breast cancer or other, can they use a local vaginal estrogen? And the answer is yes. And this is not controversial even among oncologists, because we have looked at lots and lots of data that look at how much your serum estrogen levels are raised, and long-term for women with a breast cancer diagnosis, does it increase risk of recurrence? And we know that it does not. So when it comes to local vaginal estrogen, oncologists are comfortable with that, breast oncologists. I gave grand rounds at Yale to the breast service last year, and I got no pushback from any of the oncologists there about using a local vaginal estrogen, but there's a lot of fear.
There is. And there are still oncologists out there who won't give it to the
I know.
patient,
And the problem is you don't want to put the woman in the middle, because when she comes to me and says, I don't know what to do, you're telling me it's safe, and my oncologist is telling me it's not safe. And of course, you don't want to get in the middle of that relationship because their oncologist saved their life and is taking care of them. And you don't want to sit there and say, well, he or she may not know the data, even though they may not. And so, at the end of the day, someone is going to do what they're comfortable doing. And I would never try and talk someone to doing anything other than what they're comfortable doing. But all I can do is say, this is the data. These are articles that may be useful to you and your oncologist. And I give links to that so that people can at least get accurate information.
Yeah, no, that's so true. And I tell everyone, even my friends who had like no menopausal symptoms in their 60s, I'm like, you got to get vaginal estrogen. Just ask your doctor. So I think it's a great tool. Yeah. All right. So my wife doesn't want to have sex anymore because of the pain. How do I help her help herself?
This is a huge issue, and it's multifactorial, because let's talk about two different scenarios. What I'd like to do is to talk about the couple that has been married for 30 or 40 years versus the woman who is 55, 60 years old. She is now single, she's out there, and she is dating.
Yep.
Because it's very different.
It is.
It's very different. Yes. So let's talk about the couple that's been together for 40 years. And first of all, you've got to look at, okay, what was their sex life before menopause? So there's that. You also have to look at, most women who are menopausal, with rare exception, their husbands are at least as old as they are, if not older. And very often they have their own problems as well. And it's interesting because, I do so much research in orgasm. And when you look at women with difficulty with orgasm, it actually mirrors erectile dysfunction, which is not surprising because the penis is just a big, less sensitive clitoris. So if you look at, at age 60% of women will have some difficulty with orgasm. 60% of men will have some problem with erectile dysfunction. Right. So when we look at a couple we have a woman who has pain with penetrative sex and a long-term partner who is concerned about that, what we need to find out is, first of all, don't assume that this is important to them. As a clinician, I have to find out, is this important to you? If it is, yes, let's work on this. Let's do this. But the first is, if at all possible, I'd like to get their husband, the male partner, in, because it's important that men understand what's going on. If she's cleaning out the linen closet at 11 o'clock, it's not because she doesn't like you. It's because she's in avoidance mode, because she's doesn't want to have pain. We have a lot of men who won't even initiate any affection or sexual activity because they assume that this is going to lead to intercourse, and they know that that's going to be painful, and they don't want to hurt their wife. So it's like everything else when it comes to relationships. It's all about communication. There has to be communication. And when I wrote Sex RX, which was a comprehensive sexual medicine book, one of the things I would tell women all the time is, use my book as an opportunity to have this discussion. You're reading this book and you go, oh my God, look here. I'm reading this book and it says that, and isn't that interesting? And draw the guy into it, because it's like everything else. They need to be educated, but you don't want to make them feel stupid. You don't want to say, oh my God, you have no clue, do you? You don't even know what's going on with my vagina. My vagina is like the friggin' Sahara desert, and you think I want to have sex? You're not going to get anywhere with that.
Right.
It's, boy, there's just so much happening and changing in my body. And the good news is I saw my doctor, and we can get this all under control. We can fix this. I can restore my lubrication, my this, my that. I want you to understand what's going on. I want you to be part of this discussion, because they do want to know. They do want to help. And that's the communication part. It's the education part. In a perfect world, men would learn about this when they're in their 20s and 30s and 40s. It shouldn't be like this is a big mystery, and that's kind of the goal. But the other thing that we run into that's a little bit trickier is the woman who has not been sexually active, other than maybe with herself, for some time, because she's lost the spouse or divorced or just single and just kind of had a dry spell for a while. And so now there's this idea of, how do I get my vagina back in action after a long hiatus? Ideally, it's something I would like someone to do before they get into a new relationship so that they're good to go, but it doesn't always happen that way. I think the number one message is there is no expiration date on your vagina. If you haven't used it for 20 years and the opening is like the size of a Twizzler, and you just think, no way, no how is anything going in there, a sexual medicine expert can reverse those changes. It's not going to be overnight, but it can be reversed. And that's not true for everything in life. There are some things that if you miss your window, you miss your window. There's nothing you can do. you've lost a lot of bone, not, necessarily going to get a lot of it back. Your vagina's, shrunken, we can fix that.
That's great, because how many women heard you use it or lose it?
I hate that expression. I hate it so much, because what ends up happening is women say, okay, it hurts and it's because I haven't been using it, so now I've got to use it more. So then they start to have painful penetrative sex, which is something that no one should ever, 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 ever do. Number one, because why should anyone do something painful when it should be pleasurable? But the other reason is every time you have painful sex, it gets worse. Why does it get worse? Because your pelvic floor muscles will contract in a keep out mode. You're going into protection mechanism. And beyond that, your whole vagina is trying to keep that penis out because it hurts. And therefore, you will get even drier. So, Number one is, if you are having painful sex, do not use it. Have as much sex as you want, but don't put anything in your vagina. Oral sex, anal sex, vulvar sex, clitoral stimulation, do it all, but nothing goes in that vagina until you will be pain-free. And of course, we have ways of knowing when you're going to be pain-free. We use different dilators and mechanisms and all that. But this idea of, well, then you better start using it, otherwise you're going to lose it. No. Now, having said that, if someone is having pain-free penetration and there's no penis in their life, yes, putting something in the vagina on a regular basis is going to help in terms of maintaining elasticity and lubrication. And therefore, it's so many women when they're masturbating, when they're self-stimulating, self-pleasuring, whatever you want to call it, when they don't have a partner, they're just doing external clitoral stimulation because, why not? That's, go for the gold, go for the low-hanging fruit, and that's going to give them the orgasm, and vaginal penetration is not. But the problem is, if you don't put anything in your vagina, it is going to potentially increase the chance of causing dryness and loss of elasticity, so that when you do want to use it, you're going to have some repair work that you need to do. So my recommendation is, if you are between partners, but having penetrative sex is going to be potentially important to you down the road, you are well served to put something in your vagina on a regular basis, your rapid vibrator, whatever you're using, but not if it hurts. If it hurts, don't put it in there. Then, you need to start saying, hey, I got to get this in shape for when I do want to do this, but never, ever, ever force it.
I have a girlfriend who had very painful sex after a long hiatus and ended up getting the Mona Lisa, the laser treatment. Yeah. And she said that, her doctor didn't even know about it. She heard about it somewhere else, went to get it, and went back. Her doctor said, oh my God, this looks like a young vagina, a young vulva, a young vagina. What do you say to that as a treatment, or is that one of many? It
is one of many. And so I ran the laser program. I started the laser program at Northwestern, and we had a very robust laser program, which is still going on at the Northwestern Center for Sexual Medicine and Menopause. And I'm actually involved in a multi-center trial right now with a number of universities, Yale, Cleveland Clinic, Mayo Clinic, a number of them. And we're looking specifically at CO2 laser in women with a breast cancer diagnosis, but of course anyone can use it. The short answer to your question is we can pretty much accomplish what we do with the CO2 laser in a woman who has vaginal dryness. We can accomplish pretty much the same thing as we do with the local vaginal estrogen. And so what would happen when a woman would come into the clinic and say, I'm interested in laser, and we would do an evaluation and say, yes, you have genital urinary syndrome, menopause, vaginal and vulvar dryness and thinning of the tissue. And then we would kind of go through the whole song and dance of, and these are all your options. You can use vaginal estrogen, DHEA, or CO2 laser. And a lot of these women had not even been offered all those other options.
Well, they're also
very expensive. Yeah. And that's exactly it. They thought that they had to cough up all this money. So the bottom line message is, in the right person, in the right hands, who is doing it correctly, you can very often get a result which is going to be comparable to what you will get with a local vaginal estrogen. But it will not be covered by insurance. It does need to be repeated on an annual basis. And certainly for the woman who can afford it, who prefers not to have to do something on a regular basis, it is certainly a safe and effective option. I don't talk about it a lot, not because I don't think that it's safe and effective, but because, quite frankly, most women can't afford it and they don't have access to it. And we have so many options out there that are either less expensive and or covered by insurance.
Is it age? Like, can you get it at no matter what age?
I've done it in 9-year-olds.
Wow, it's good to know.
With good result. That's the other thing, too. When we talk about treating this, there's a big difference between someone who has mild changes versus someone who has very, very severe changes that have gone on. We talk about a long hiatus. If someone has had genital urinary syndrome, menopause, and dryness for 20 years, and nothing has gone in there for 20 years, this is not going to be an overnight fix. We're going to get there as long as you're motivated to stick with the program. But it's very different than the woman who says, I've never stopped having sex. I'm still able to have sex. It's just kind of hurts. Can you help me? And it's like, yeah, I can help you, and this is not going to take long at all. So you need to be evaluated, and you need to get a treatment plan that is specific to you.
I want to be mindful of your time, but just to wrap up, what are some of the things that women would not necessarily link to pain, vulvar pain or vaginal pain or pain with sex? For example, Dr. Joel Kim talks about spinal issues, like issues with the back, which I feel like, so what are some of the usual ones?
And well, that brings me to pelvic floor physical therapy, which we touched on. People don't think about these pelvic floor muscles. The hip bone's connected to the knee bone. Well, the back muscles are connected to the pelvic floor muscles. And I cannot tell you how many women come in with painful sex and we have them get pelvic floor physical therapy and they're like, oh, now my back pain is gone. And we see the opposite. They get physical therapy for their back pain and their pelvic floor pain is better. So that would be number one on top of the list, is looking at pelvic floor pain, and then maybe it's hip pain, it's spinal pain. Post-menopause, we see women that have joint aches and pains, which prevents them from not only getting into a comfortable position, but any pain is going to kill your libido. No matter what the pain, it could be headache pains, doesn't matter. Any pain is going to decrease your ability to have an orgasm, because it is impossible to become aroused when your brain is working on the pain instead of working on becoming aroused. But the other thing that I go on and on and on about are SSRIs, because so many women are given SSRIs for treatment of menopausal issues. Now, I want to be very clear and differentiate from the woman who's given an SSRI that she started premenopause and it's a treatment of anxiety, depression, and all of that, versus the woman who's given an SSRI specifically to treat menopausal symptoms, such as perimenopausal anxiety, insomnia.
Well, how do they know it's perimenopausal? I mean,
an expert's going to be able to help them figure that out. Or someone very common who is going in with hot flashes, and because their doctor is not a menopause expert and because they're not comfortable with hormone therapy, they will prescribe an SSRI, which can decrease hot flashes. And for that reason, we are looking at almost 1 out of 3 postmenopause women are taking an SSRI. Most, not all of them, most of them do not need to be. And as a result of that, we are having women that are having a lot of sexual problems, loss of libido. So one of the things we haven't talked about that I want to talk about for a minute is my podcast. We talked about my Inside Information podcast, which I'm now in my 4th season. And
unbelievable. I learned
downloads on
I think everything about menopause I learned from Dr. Streicher.
We're going to learn a lot more on Come Again. Come Again is a podcast that I recorded. This is a limited podcast, meaning it's not ongoing. I have 31 episodes, so women can get it as a package. And it is an entire textbook in podcast form of sexual function during peri and postmenopause. I did this with an audience that includes both medical professionals and women who are not medical professionals but are looking for high-level information. I have an episode on what if your SSRI has killed your sex life? What if your hysterectomy has killed your sex life? What if you have breast cancer? What if you can't have an orgasm anymore? Let's look at testosterone. Let's look at the arousal claims. Name a topic, I have an episode on it. 31 episodes, I cover it all, and quite frankly, if every single healthcare professional in the country listened to this 31 episode podcast, they'd be able to help their patients a lot. So Come Again, you can actually, I do have it on Substack, and my Substack paid subscribers do have access to it at a certain level, but I am also going to be it's available to get it as a set thing without going on Substack. So if you go to my website, drstreicher.com, and it's STREICHER, drstreicher.com, there will be information there on how to access Come Again, how to get to my Substack, all of that.
And I'll put all the links in the show notes. Dr. Streicher, thank you so much. We are at the Sexual Health Alliance conference, and I grabbed Dr. Streicher at the end of a very, very long
It has been a long day, but good.
So thank you so much for being here. I really appreciate it.